Thank you very much for the introduction. Thank you. It's an honor to be here. It's a privilege. It's at this great venue. Very impressive, Harry, and thank you for the invitation. So I've been tasked to talk about interventional pulmonology year in review. Impossible task in 15 minutes, I would say. So I'm going to crack on, starting with the disclosures. These are my financial disclosures. You can see there on multiple screens. But I also would like to sort of highlight that I'm a researcher, investigator of a pulmonologist, interventional pulmonologist. So I pick the stuff that I talk about based on my own interest. And I do have my own opinions as well. So wherever you see that signal there, that means that I'm just basically making it up. So take it with a grain of salt, if you agree with it, or if you don't. So starting with the volume of research we have seen in last year, in the last 12 months, if you search interventional pulmonology in PubMed, you get 431 in 2024, and you can see that this logarithmic increase started about 15, 20 years ago, continues despite a bit of a hiccup around COVID time, so it's recovered and it's going on quite strongly. It'd be impossible to talk about 431 studies, but I've done a word cloud, and you can see that bulk of the literature is focused on bronchoscopy and diagnostic bronchoscopy in the context of lung cancer. So that's what I'm going to focus on. I've picked these based on my own interest and what I found interesting. So apologies to the ones that I've missed out, but focusing on nodules, diagnostic and therapeutic. Moving on to Lydia Eba's cryobiopsy. I know it's been talked about already, so I'm going to skip a couple of my slides. And also a few slides on bronchoscopic treatments of COPD as well. And what to look out for in 2025. It's going to be speedy. I'm not going to go into details because I just want to cover a few slides. Obviously, the details are there and you can look them up. I really want to discuss the statement, the consensus statement that came out in March 2024. Obviously, a piece of literature that's very important to discuss, but I want to start by a little bit of introduction, and it's fair to go back to 2022, talking about Vakani's publication on diagnostic yield. Important to highlight that this is a hypothetical cohort of 1,000 patients. It's not a clinical study, it's a simulation study based on what was reported in the benefit study. So pretty much doing some calculations to see, you've seen that already in some of the slides earlier today, that the definition of diagnostic yield pretty much depends on what you consider to be true positive, can significantly affect the diagnostic yield in the same test, the same cohort of patients. It can be variable from 66% if you're very strict and only consider specific benign and specific malignant diagnosis as true positives, all the way to about 89% if you consider other things, including follow-up and so on and so forth. Moving on to the actual statement, it came out in March 2024. A group of experts on behalf of ATS and ACCP basically published 15 statements acknowledging the fact that there is variability in reporting outcomes of bronchoscopic lung nodule biopsy trials, which is a fact. They mentioned specifically ACQUIRE versus NAVIGATE, trying to explain why diagnostic yield was different, but also talked about the fact that if you have multiple studies that have been defining diagnostic yield in different ways, it will be impossible in the future to pool that data into a meta-analysis. That's also a fact. But they go even further and mandate the use of this strict definition of yield in studies, which I thought was a bit strange anyway. So if you wonder what is specific benign and what is not specific benign, I can tell you that this is what they have published. Obviously, we know about malignancies, but specific benign diagnosis is the list that's there. So even if you have a patient with a pretest probability that this is an inflammatory nodule, and you do a biopsy and you've got proof that tool is in the lesion and you do get inflammatory cells, in that scenario, that test is still considered to be non-diagnostic. Credit where it's due. So Vakani actually did another simulation with the team. Again, this was published in 2023, but looking at 1,000 index bronchoscopies, this time we're not talking about same test, same group of patients, different diagnostic yield definitions. We're actually talking about same diagnostic yield definition, same test, but different cohort of patients. You've already seen this in Joe's talk. This highlights a very strong relationship between cancer prevalence in the cohort of your patients affecting the diagnostic yield. So it makes things a bit more complicated. I mean, even if you have strict yield, still can't compare two studies because the cohort could be completely different. Depends on how many cancers you have. It also, I think, explains why we have difference in real-world studies in their yield versus the clinical trials, the prospective ones, and that the reason is because we are very selective in the prospective ones. The pretest probability of cancer is higher, usually around 70–75%. That brings the diagnostic yield higher. But when you're in clinic and lesions and nodules are referred to you and you can biopsy them, you do them, cancer prevalence in those cohorts is usually around 50%. Your diagnostic yield drops. So these are important things to consider. I'm going to move on from that. I'm very passionate about it. I just have to move on in life. So in terms of summary, the definition of yield is variable in studies. We've talked about that. The new consensus statement mandates the strict method of reporting yield, but it's affected by prevalence of malignancy. But it's not a clinical tool, though. It's never been defined or tested or based on any clinical setting. And this brings us to the fact that I think I'm glad to see that we are all saying the same message, that maybe with advancements in technology, when you've got a new tool, you've got to look at it and see, all right, what is this tool supposed to do for me? And what am I expecting from it? And then define an outcome that's relevant instead of relying on accuracy or diagnostic yield, which is a very compound and complex outcome. As an example, I'll show our study that we defined reach and tooling lesion as our outcome, which I think was relevant to that study. The disclaimer goes on the side of that. That's my opinion. All right, moving on. I have picked this one because this is interesting, as we don't see many head-to-head studies these days. So this is head-to-head between shape-sensing robotic-assisted bronchoscopy versus transthoracic needle for GGOs and subsolid lesions. Again, we don't see a lot of GGOs and subsolid studies these days. So that was interesting. The diagnostic yield was reported to be very similar, 85 versus 89. Small group of patients, though. So we've got 38 in one side and 28. You've got to consider the fact that it's retrospective, two-center study. It's Mayo in Florida and Mayo in Rochester. And interestingly, well, it does show that the robotic bronchoscopy procedures are much longer, 72 minutes on average versus 21. Not sure it's because we have the opportunity to do more biopsies with different tools, as you can see in that column a little bit higher up as well. Or is it because we do staging? The study doesn't specify that, but in reality, that's a very strong factor. In terms of complications, you can see there's a trend towards higher pneumothorax rates in the transthoracic one, at the expected reported rate of about 20%. Again, the p-value there is not significant because of the size, I believe. Step by step going forward on the nodule topic, advanced imaging is probably the most important advancement in technology we have had when it comes to lung nodule biopsy, bronchoscopic lung nodule biopsy in the last few years. And this beautiful Belgian study prospectively randomizes the patients that were referred for biopsy into either EMN with fluoro or EMN with CBCT. Again, small numbers, but they were similar in characteristics. They were mostly solid, so there were some subsolids in there as well. And the prevalence of malignancy in that cohort was about 72%. You can see that adding advanced imaging significantly increases diagnostic yield and diagnostic accuracy. We're talking about 3D in this study, cone beam CT. Reach increases as well, as however, it does contribute to a bit of a longer procedure as well, as you would expect. Another step forward, advanced imaging, when it's combined or integrated with your navigation system. So you've got the navigation system in the previous study, you've got the advanced imaging in the previous study. Now, if you combine them together, make the advanced imaging talk back to your navigation, you can overcome CT to body divergence. And you can see that on the picture there. So this is a study that we performed at Macquarie University Hospital, published earlier last year in 2024. First in-human trial of Galaxy system, which is an image-integrated robotic-assisted bronchoscopy using DT. We defined our outcomes based on the technology, reach in terms of navigation, that's important, that's relevant to navigation directly. Tooling lesion is relevant to the advanced imaging and its integration. We reported on yield on strict as well, which was 89.5%. Moving on from diagnostics to therapeutics, the literature is thin for many reasons, as was explained before, but this is another study that was actually collaboration between Melbourne and other sites as well. Dan Steinfurt is a friend of mine in Melbourne, first author there, of course with Felix. First in human safety and feasibility of RFA catheter, obviously has been used transthoracically with multiple complications in the past, but this is a novel catheter that cools down externally as well using saline. Lots of lessons learned. This is a very good example of you design a study, you do it, you publish it, and everybody learns. So the first patient was not paralyzed, and as you can see in picture A, the patient had a cough, was coughing, and hot saline moved, and you can see that there is not a lot of overlap. If they changed the protocol, they paralyzed every patient, they treated another 7 patients with no significant serious events, and the ablation zone included tumor in all of those cases. However, the overlap was a bit variable between 8 and 72%. So this was a dose escalation study. Interesting study. Hope we see more of those larger ones, phase 2s and 3s. I'm going to move on to linear EBUS cryobiopsy very briefly because obviously Jürgen talked about it and you've heard a bit about that as well. I really like that study that has already been presented. It really confirms what we thought the value of cryobiopsy is, which is in increasing the yield, overall yield, but it has almost no effect on lung cancer cases. In fact, its value is in benign lesions, benign disorders, and also uncommon tumors, as you can see in that graph. I'm going to skip that one. Also, I think this was also mentioned as well. This is a recent study published comparing forceps and cryo, and again, Jürgen talked about that. I'm not going to mention much here. Now, moving on to another topic, I've got, I think, 2 or 3 of these on bronchoscopic treatment of COPD. We know that there's a lot happening, but a lot of them have not been published yet. This was very interesting to me because we've all been referring back to the NET trial and poo-pooing surgery based on those results. It's good to see an updated version of that. because obviously bronchoscopy and everything else has improved over the last 2 decades. It's just fair to assume that surgery has also moved on and improved. So this was a multi-center, UK-based randomized trial, lung volume reduction surgery versus bronchoscopic lung volume reduction, follow-up at 12 months. You always have the non-responders, and then you have the responders. And you can see surgery on the right and bronchoscopy on the left. CAT score, the row below, and residual volume on top. Obviously, the concern with surgery is its short-term complications. The study didn't find any signal there. However, it's fair to also highlight the fact that the size of the study, the power of the study, may not be high enough to have a safe conclusion there. Specifically when you compare that to the NET trial, which had more than 1,200 subjects enrolled. But altogether, very interesting and very useful study. It's also good to see the coils coming back. So I'm sure you guys are aware, had them around 15 years ago, 10 years ago, started fading away. Now this is a new coil, pretty much the same thing. So it's shape memory nitinol device that's placed bronchoscopically. But instead of the kind of the bouquet of flowers we used to see with the coil, it's a bit more, it's like a bouquet of flowers that someone has crushed. Because they have different 3D orientation, and that induces more lung tension. Aiming to have more reduction in residual volume. These are the adverse events there. No significant or concerning signals there, which is always good to see. Also, always good to see that the cohort of patients chosen are the relevant ones, and these definitely are. Severely obstructed, severely hyperinflated, with appropriately low DLCO, as you would expect. And these are the results there. Again, a couple of non-responders, and then the responders. In terms of symptoms, you've got the SGRQ there in the middle there, 6-minute walk test here as well. So only a proportion of them reached a minimally significant change or difference. But again, good trial, hope to see more of these, and larger ones as well. So this is my summary slide. Was trying to stick to time. I'm sorry if I've gone over, but that's why it's a bit limited as a review of the year. Obviously, the year was much bigger than these. But I think it's important to sort of, these are my impressions after kind of going through the literature, that there is significant momentum behind early lung cancer diagnosis and the advancements that we have seen, which really the evidence now puts bronchoscopic lung nodule biopsy not just on par, but maybe ahead of traditional methods. But independent and investigator-initiated studies are still rare, and if they are there, that they are very low-powered. Head-to-head studies don't exist. They're very unlikely to ever happen. Now, the talk of the town everywhere you go about, advanced imaging and bronchoscopic lung nodule biopsy is therapeutics, because that's the next step. There's a lot happening, and we know that there are a lot of ablation therapies are available clinically and commercially, but in relation to that, the literature is very thin. What to look forward to, hopefully, this move that we have seen in the last few months, maybe the last year, that the technology has moved out of the United States, and now we are seeing that spread in Europe, Asia, and in Australia. Hopefully we can see real-world and independent literature now emerging as well from these sites to contribute to the bulk of the literature. And also, in terms of COPD treatments, bronchoscopic COPD treatments, there are a few things in the pipeline, including the CONVERT trials and APRIO and BTLA that hopefully we'll see in the next year or two. And I would like to thank you for your attention.